All right, guys, I think we're all ready to go now. Tonight's lecture series is entitled Bite Me, which means we're going to talk about dental anatomy, structure, and function. We're also going to talk a little bit about just the oral cavity in general and some neck muscles along the way. So we'll go ahead and get started. Just a fun fact I wanted to bring up first is the toothbrush has been around for a really long time. Actually started in 4000 BC in India, and the Babylonians in 3500 BC called this thing the chewing stick. And then in China in about 1600, they started using hog bristles for a toothbrush. And finally in 1780, a guy named William Addis in England invented a brush used to clean teeth, and now we have a toothbrush today. So maybe that's not really a fun fact. I thought it was kind of fun. So we're going to start by talking about dental anatomy and development. We have just the basic anatomy first. The first thing you have to know about dental anatomy is the bones that the teeth are actually a part of. So you have two primary bones that hold your teeth. The first is the maxillary bone, or the maxilla, and that is this bone that forms and holds all the upper teeth. So all of your upper teeth are rooted into the maxillary bone, or the maxilla bone. The mandibular bone, also known as the jawbone, so we commonly call our jawbone the mandible or the mandibular bone, holds all the mandibular teeth, and these are your lower bones. So if I say something about maxillary teeth, those are all your top teeth. All your lower teeth are your mandibular teeth because they're in the mandible. This is kind of tricky, but just as far as referencing what surface of the tooth we're talking about, there's several obscure terms. The first term I want to throw at you is the buccal or buccal surface. That's B-U-C-C-A-L. It's right here. And that is referring to the side of the tooth that is touching the cheek. So if you have a tooth that is touching the cheek, that surface is called the buccal surface. Likewise, if you have one of these front teeth up towards the front of the mouth, or the anterior side of the mouth, the surface that is touching the lips is called the labial surface. So you have the buccal and the labial surface, depending on whether it's touching the cheek or if it's touching the lips. If the surface is touching the tongue, then it's called the lingual surface. So the lingual surface is opposite of the buccal and opposite of the labial surface. Then in between teeth, you have two different surfaces. You have the mesial and the distal. If you draw a line down the middle of the mouth, the mesial surface of the tooth is closer to the midline, and the distal surface is further away or more distant from the midline. So if we say the mesial surface of a tooth, we're referring to that side between two teeth, the side of one tooth that is closer to the midline. And probably the most commonly used surface that I'll talk about is the occlusal surface, and that's the side of the teeth that you chew with. So as you're chewing food, the occlusal surface is the surface that is contacting that food. So that's the top part right here. You guys may have heard these two terms before, but I'll go and bring them up. Crown and root. So think of a king. He wears a crown on top of his head. Likewise, a tooth is going to have a crown on the top of it. So the crown is the part that is visible. So if you look inside someone's mouth, or look in the mirror and look in your own mouth, you'll see that the crown is the part that is visible without going any further. The root, just like the root of a tree, is keeping that tooth grounded into the bone. So either the maxilla or the mandible. So the root is anchoring that tooth into the bone so that it doesn't fall out. Another term we want to talk about is the cusp. So certain teeth have cusps on them, and all a cusp is an elevation or a point on the occlusal surface of certain teeth. So remember, the occlusal surface is that top part. So certain teeth, like the canines, the molars, and the premolars, they all have these cusps. And that's how you differentiate some teeth from other teeth, how many cusps they have. And another thing that dentists can often use to identify teeth and to sort of point out landmarks on teeth is the ridges involved on the teeth. I'm not going to get into this, but there's a lot of different ridges. There's the buccal cervical ridge, the mesobuccal cusp ridge, the transverse ridge. It's not really important for what we're talking about today. I just wanted to point out that there's a lot of diversity when it comes to teeth. There's a lot of, every tooth is really different. I think I take it for granted that, you just think a tooth is a tooth, but really every tooth is slightly different. And these ridges play a role in that. There are four main components of the teeth. There's the enamel, which protects the crown. So remember, the crown is on top and it's visible. This enamel is like, think of it, if the crown is on top of the head of the king, think of the enamel as like the shield of the king. It's protecting the tooth. It's the hard surface that's protecting from bacteria and from cavities and things like that. If you start to wear away at your enamel, it's really hard to get that enamel back. So you really want to protect your enamel so that you can protect your teeth. You have dentin, which makes up the inner surface, most of the inner surface of the tooth, followed by the pulp, which is the innermost surface. And the pulp has the nerves and the blood vessels. So all your arteries, veins, and nerves are all in the pulp. And you have cementum, which the enamel covers the crown. The cementum covers the root. So the cementum is a hard surface on the root of the tooth. You've probably heard the term gingivitis. Gingivitis is referring to inflammation of the gums, and another term for gums is gingiva. So gingivitis is inflammation of that. The gums are the soft tissue around the teeth, and they seal off the tooth. So every tooth is anchored into the bone, but the gums help kind of keep them in place as well and help keep food from getting too far in between teeth, and it just helps with preventing infection and things like that. And the point I want to make is the gums are continuous with the mucosa of the mouth. So mucosa is a fancy word that we use to refer to the lining of the mouth. So your entire mouth is lined with mucosa. And if you see up here, this is mucosa towards the top of the mouth. As you continue down, it turns into gingiva, and you have what's called the mucogingival junction. So muco, meaning mucosa, gingival is the gingiva. So there's a junction between this continuation of the mucosa and the gingiva. There are four classes of teeth that we're going to talk about. The first is incisors. So these are the teeth that I think of as, if you think of buck teeth, or as you can see in this baby's pacifier, they're the four anterior top teeth and the four anterior bottom teeth. And when I say anterior, I mean in the front. So your four front teeth or anterior teeth are incisors. They don't have any cusps. So if you think about your front teeth, they're very flat. There's no elevations on the occlusal surface or the chewing surface. They're used for shearing and cutting foods. So you don't grind with these teeth. You don't just sit and chew with your front teeth typically. You chew with your back teeth, which have better surface for that. So these are for shearing and cutting food. Then we have canines, which I've heard called the cornerstone of the mouth. If you've ever seen a vampire film, these are the teeth that are typically very over-embellished. And what they're over-embellishing in vampire films is that single cusp. So these teeth are often called the cuspid. They're called cuspids because they have one single cusp. And they're used for tearing food as well. And these are just past the incisors. So they're the next as we go towards the back of the mouth. After the canines, you have premolars. Now, premolars are called bicuspids because there's two cusps. So canines only have one cusp. They're called cuspids. Premolars are right after the canines, and they're called bicuspids. And you have two sets on each side and on top and bottom. So you have 8 total premolars. And the function varies because they're kind of a hybrid between a molar and a canine, and they're not included in baby teeth. So young kids do not have any premolars. And you can see in this picture just that there's 2 elevations. Those are the cusps. And molars, these are the most posterior teeth. And when I say posterior, I mean towards the back of the mouth. So these are furthest in the back. They're used for grinding food, chewing food. They can have many different cusps. They have flat surfaces for really grinding that food. There are 3 sets of molars, and the third set is often referred to as wisdom teeth which are very uncharacteristic. They vary from person to person, and they're the last teeth to come in. We'll talk a little bit about tooth development. Something that's really interesting is teeth actually begin to develop while we are still in our mother's womb. So teeth begin to form during fetal development. And if they do not form during fetal development, then the teeth will not form. So they have to form while still in the womb and while still developing as a fetus. This is why it's important that pregnant women really watch what they're eating, what medicines they're taking, because sometimes medicines can affect all types of development, especially dental development. When babies are born, they'll begin to teeth around 6 months of age. There's obvious variation. It could be earlier or later than that. The first tooth to usually erupt or to show up is one of the bottom central incisors. By the age of 3, a child should have all of their primary or baby teeth, also called deciduous teeth. And there are 20 baby teeth that a child gets. And then those teeth are lost throughout childhood. By the age of 21, you should have all 32 permanent teeth. So again, there's 20 baby teeth and 32 adult teeth. Which brings the question, why do we have baby teeth anyway? Why not just have adult teeth right away? Well, baby teeth provide chewing before the permanent teeth erupt, and the infant jaw is not big enough to accommodate all of the permanent teeth. So it can only accommodate 20. So you have 32 when you're an adult. The infant jaw is not large enough for that. They also serve as a guide for permanent teeth eruption. So they kind of maintain a space in the gum line and in the jaw line for those teeth coming up before they erupt and become permanent teeth. And they aid in speaking clearly and quickly. So if you've ever heard anybody that doesn't have any teeth speak, it's very difficult to understand them at times because they really help with phonetics. Here's an X-ray of a child. I'm not sure how old they were, but you can see that they have a mix of permanent and baby teeth. So you can see, so here's the oral cavity. You can see all of these teeth have fully erupted, and then behind them are permanent teeth budding to come in. So this just shows that both teeth are developing at similar times, and though you have baby teeth on the surface, you have adult teeth that are coming up and erupting under them. So all of these central teeth here are incisors. Those are probably permanent teeth because there's no permanent teeth under them. And then you have canines, permanent teeth that are getting ready to erupt up. And here's a skeletal representation of that. It's kind of creepy, but it's kind of cool too. So you can see in the skull, you can see all the teeth that have erupted, but you can see the permanent teeth that are embedded in the mandible and the maxilla that are waiting to erupt. So I think that's kind of a good representation of what's going on. So as I said earlier, there are 20 primary teeth or baby teeth. And you'll notice that it goes from incisors to canines to molars. There are no premolars. But the funny thing is these molars actually look a lot more like premolars. So it's just kind of an interesting fact. And the first tooth to usually erupt is the central incisor on the lower jaw. And we have 32 permanent teeth. And when we get all of our permanent teeth, we add in the premolars and we add our third molars, which are our wisdom teeth. And the first tooth to erupt is the central incisor. And the last tooth that we get in our late teens or early 20s is usually the wisdom tooth, which is the tooth that we all hear about getting extracted, because a lot of people don't still have their wisdom teeth. Numbering is a little difficult with teeth. So when you go to the dentist, they want a way to record what tooth has problems. So maybe you have a tooth that is potentially going to become a cavity in the future. They want to make a record of that so that when you come in next time, they can check it. So in the US, the way we number is we have all 32 teeth and they all have a specific number. You start with the top right wisdom tooth. So if you're looking at your patient, it's going to be on their right, your left, on the top, the very back. You start with the top right wisdom tooth and you start to count the whole top row all the way until you get to the top left wisdom tooth. And then you drop down to the bottom left wisdom tooth and then you count the whole bottom row until you get to the bottom right wisdom tooth. And so you should have 32. Now, say someone doesn't have a wisdom tooth, so they don't have a number 1. You start with number 2 and count 3, 4, 5. So you would just skip the number that they might have missing. And so it should look like this clockwise pattern where you start with the top right wisdom tooth and then sort of make a clockwise circle all the way around the mouth until you get to 32. So if someone has, if they're missing a tooth somewhere, you just skip over that number. Now we're going to talk about problems that can occur with teeth and gums. So there's a rare genetic disorder called anodontia, which occurs when a person has a partial or complete absence of primary teeth or permanent teeth. And this is a problem that they're born with. And when people have a disease that they're born with, it's called congenital. So if they have a congenital disease, it means they didn't acquire it later in life. It means they were born with this problem. They usually have other health problems. One of those is ectodermal dysplasias, which is a skin problem that occurs. There's a lot of variation that can happen. They can have all of their teeth gone, or they might just be missing 1 or 2. And you treat this with prosthetic replacement. So you can give them dentures, or if they only have 1 tooth missing, you can probably put a retainer in there with a prosthetic on there. And here's a picture. You can see that this person has 2 of their incisors, but they're missing their 2 lateral incisors. And this patient is missing all of their teeth. Dental caries is a very common problem. These are commonly called cavities. So a dental carie is the same thing as a dental cavity. And these are caused by bacteria. These are byproducts of bacteria. So as you eat starchy or sugary foods, you have bacteria in your mouth that's always there, but that bacteria starts to feast on that starchy or sugary food. And as a byproduct of that bacteria eating that food, it starts to create acid. And that acid starts to eat away at the enamel of the tooth. And again, remember that enamel is that shield that protects the teeth. If you lose that enamel, it's really hard to get it back. So you really want to brush and floss and avoid unhealthy foods. And just seeing a dentist regularly will really help prevent a buildup of this bacteria. And a buildup of this bacteria is called plaque. So if you've heard the term plaque, that's a bunch of bacteria. That's a bacterial colony that's on the teeth. To strengthen teeth and to strengthen enamel, we often give fluoride treatments. So fluoride can be used to treat teeth. It's also typically in tap water, so that helps our teeth as well. Sealants can be used. So a sealant is a piece of plastic-like substance that you put on the occlusal surface of the tooth to help strengthen that surface of the tooth. So if something is starting to decay or something's weakened, or your dentist noticed that there's a lack of an enamel, then they might put a sealant on that surface, and that will help prevent that surface from decaying. And obviously we can have fillings, which I've had quite a bit of those. And in severe cases, the tooth may need to be pulled or extracted. So here's an example. You can see that there's some severe decay going on in a lot of this. And there's fillings down here. Next thing we're going to talk about is a calculus bridge. So calculus is another term for tartar, and tartar is a term for hardened dental plaque. So as you get this buildup of plaque in your system, in your teeth, there's minerals in your saliva that actually kill the plaque, and then that bacteria is still there, and the minerals combine with it, and you kind of get this hardened substance called tartar, and that hardened substance cakes onto your teeth, and that rough surface from that hardened substance actually forms an ideal attachment for more bacteria. So more bacteria get onto the tartar, and then you get more plaque, and then you get more tartar. So if you don't have your teeth cleaned regularly, you can get what's called a calculus bridge, which is this buildup of tartar that can occur on the teeth. It's this hardened substance, and in this case, it actually pushed these teeth apart. So you can see there's actually a crack here, and that's because these teeth were once closer together and started getting pulled further and further apart by that tartar buildup. And here's a pretty extreme case of that tartar buildup. I mean, you can just see, you can hardly see some of these teeth anymore just because they're covered with tartar. Dental abscess is another problem that can occur, and this is accumulation of pus in teeth or gums, and this is caused by a bacterial infection. So what happens is bacteria come in, they infect an area, and then they become trapped. They can't move, and they start reproducing and growing in number. And if you put a bunch of bacteria in an area and they start multiplying, well, they can't keep expanding out. It's going to put pressure in that system and on that area, and it's going to cause a lot of pain. And that's just being filled with pus. And so this can be caused by a broken tooth or tooth decay or other disease. There's two types of abscesses that can occur. There's periapical abscess, which is the most common, and this is occurring when the bacteria enters the pulp of the tooth. So remember, the pulp is where the nerves and the arteries and the veins are in the tooth. Or it can occur alongside the tooth in the periodontal abscess, and that's called a periodontal abscess. So this is a periodontal abscess. You can see right above his incisor up here in the gum line, you have an abscess forming, and if you were to drain that, I'm sure you would see an accumulation of pus. You might have heard of a root canal, which can be used to treat abscesses. A root canal would be used when you have an abscess in part of the root, and so what you would do is you would take a drill and you chip away at the occlusal surface until you get to the pulp of the tooth, and you take a device that can clean out that root of the tooth, and then you fill the tooth back up after you've cleaned it all out and give it new structure and then put a new cap on it. So a root canal is essentially you're digging a canal through the root to clean out an abscess or an infection of some sort. Gingivitis is a really common mild form of gum disease. So this isn't a serious problem, but it can lead to serious problems. So it's usually the first sign that maybe you're not having the best oral hygiene or that you need to do something different. But it's essentially just an irritation and swelling of the gums that occurs. Receding gums is something that can occur typically in adults over 40, but it can occur in teenagers as well. It's called gingival recession as well. And this is when the roots become exposed. So remember, in a normal, healthy mouth, only the crown is exposed. That's all you see. But in receding gums, the gums start to drop a little bit, and you start to see the roots become exposed after a while. And this can be caused by a lot of things. This can be caused by over-aggressive brushing or improper flossing or chewing tobacco. And what they do to replace this, because your gums won't necessarily go back. Once they're receding, that's pretty much where they're going to stay unless you have a surgery where you actually implant gums over where they receded. And the way they do that is they actually take a cadaver. So they take gums from a dead person and they put it into your mouth. So it's kind of a gross surgery. So don't brush too hard or you'll get dead person in your mouth. Scurvy is something that can affect a lot of parts of your body, but really something that it commonly affects is the gums. And this is vitamin D deficiency. So if someone is vitamin D deficient, if they're not eating enough fruits to have vitamin C in them, then they can get scurvy if it's happened for a long period of time. This isn't going to happen if you just don't eat an orange for a weekend or something. Vitamin C is used to make collagen, which is a major component of your connective tissue. And connective tissue is just what it sounds like. It's tissue that connects. So your skin has connective tissue. Your gums have connective tissue, which brings us to this picture. If your gums have connective tissue and you're having issues with making connective tissue, then you get severe irritation of these gums. So you can just see how unorganized the structure of these gums looks like. And that's just because the connective tissue has just gone AWOL. And I put a pirate flag up here because this was common with pirates, because pirates would be at sea for a long time back in the day, and they wouldn't have fruits on board, and so they would become vitamin C deficient. And so if you ever hear of a pirate getting scurvy, that's why. It's because their diet lacked vitamin C. And just another fun fact, dental toothpaste has been around for a long time as well. So since 500 BC, we've had dental toothpaste. And in the 1800s, there was a doctor that actually started adding soap to it, and they started adding more things to it. In 1892, they invented the collapsible tube that we use today. And since World War II, our toothpaste really hasn't changed too much because they added fluoride during World War II. Now, teeth can tell you a lot about particular animals and what they eat and their diet and how they act. And so I just wanted to kind of go through and compare just a few animals. We just talked all about human teeth, but now we can talk about dogs and cats and some others. So dogs, like us, go through 2 sets of teeth during their life. Their canine teeth are the most prominent. I mean, that makes sense, right? Because dogs are canines, so their canine teeth are the most prominent teeth that they have. Cats likewise have 2 sets of teeth during their life, but all of the cat's teeth are very sharp. Even the molars don't have grinding surfaces. So all of the teeth in a cat are really sharp. So that's going to tell you that a cat is more of a carnivorous creature than one that's going to eat a lot of plants and things like that. Sharks shed and grow new teeth all the time. So they can have up to 35,000 teeth shed in one lifetime. And they have multiple rows of teeth. So some species can have up to 50 rows of teeth, which is incredible. And snakes, when we think of snakes, we think of fangs a lot of times, or at least I do. And most snakes have teeth, but not all snakes have fangs. And fangs are a sort of modified tooth. They're long and they're hollow, and they're connected to a small sac that contains venom. So when they bite into their prey, that venom is going to travel through that hollow fang and into the prey. So here's a picture of a dog, and you can see that the canine is quite prominent. And if you go towards the back, even some of the molars, there is a little bit of flat surfaces, but it's much sharper than what ours are. With a cat, similarly, you have it's just sharp surfaces all around. So even the molars back here are very sharp. And then here's your shark. You can only see 2 rows on this shark. So you can see 1 and 2, 1 and 2 right there. But they are constantly losing these teeth and just regrowing more. And then you have a rattlesnake here, and you can see the fangs out front. And I just wanted to throw out some kind of interesting animals and some weird teeth out there. So this is babi rusa, which is also called a deer pig, and these are in Indonesia. And this pig right here, these aren't horns, these are actually modified canines. So these are actually teeth that are going through the roof of his mouth. So this is all the roof of his snout right here, and these are going through that and curling back. And here are the canines on the bottom that are curling back too. So these aren't used for chewing. These are more for probably attracting a mate or for defense. There's a musk deer here. I've heard it called a saber-toothed deer, and these are in the Himalayas in Asia. And you can see that their canines extend down far. Interesting thing about these guys is when we think of deer, we think of antlers. These actually don't grow antlers. These grow giant, creepy vampire canines. It's kind of weird. And the narwhal, which I've heard called the unicorn of the sea, they have this giant horn-like projection that comes off of the front of their head. And you would think this might be similar to like a rhino horn or something like that, but really this is a modified canine as well. So this is actually a tooth that they can use for defense, and they can also use it to break ice and things like that. And of course, when we're talking about teeth and weird animals, we got to talk about the piranha. So the piranha have these vicious triangular teeth, and you can't see it very well in this guy, but the top row also has teeth as well, and these teeth interlock with each other. So you can just tell how pointy these are. These are definitely used for just shredding whatever their prey is. And we're going to take a little step back from teeth for a while before we do our lab, and we're going to talk about taste and taste buds. So taste buds are the receptors for taste, which I'm sure you all knew. We each have somewhere between 2,000 and 8,000 taste buds. They're located on structures called papillae, which are little elevations on your tongue. So if you look at someone's tongue, you'll notice that it's rough. It's not just a smooth tongue. And that's because your tongue is covered with papillae. So papillae have taste buds, which is one of the functions. They house the taste buds. But another function of papillae is they kind of offer grip for your tongue. They allow they allow friction for food, so you can manipulate food when you're chewing. And so they kind of do the same thing that, your hands have fingerprints for grip. Your tongue has papillae as a rough surface that you can manipulate food and chew more easily. there are 5 elements of taste perception. There's salty, sour, bitter, sweet, and then one that I hadn't heard of called umami, and this is Japanese for pleasant, savory taste. And I've read that tomatoes are rich in this umami component. So if you think of a tomato not really being salty, sour, bitter, or sweet, but it's kind of its own thing, kind of associate tomatoes with umami as that kind of element. But it's not one we talk about a lot. So talking about the papillae, there's 4 types of papillae. There's fungiform papillae, and I'll show you pictures of these in just a second. But fungiform, think of fungus or fungi. They look like mushrooms. So mushrooms are fungus. These look like mushrooms. Filiform papillae, these are the only papillae that do not contain taste buds. These are very long and thin, so they're just filling space. They're just there for making the tongue, sort of giving it its rough texture. Foliate papillae, these are towards the very back of the tongue. And then you have circumvallate papillae, which you only have 10 or 14 per person, and these are larger than the others. And here's a picture of a circumvallate papillae. So this is a cross section, so we cut all the way across it, and this is a microscope slide of that. And you can see that there's this valley. So think of circumvallate, think of a valley, and it circles the papillae. So you have these valleys that surround the papillae. And if you look over on the sides, you see these little circles. Those are actually taste buds. And so when you taste something, so say you're drinking sweet tea, and sweet tea goes down in this little valley. It goes to the taste bud receptors, and it goes to your brain telling you that it's sweet. But when we drink sweet tea, we don't taste that for hours and hours. So it doesn't just sit in this valley. What happens is you have glands here that excrete a substance out into this valley, and it actually cleans out the taste buds. So that's why when you eat chocolate cake, you don't taste it for days. It doesn't just sit on your taste buds. You have structures, you have these glands that actually sort of wash out the taste buds so that you can taste new things. Fungiform papillae, as I said, this is a cross section of it. This is mushroom shaped, so you can see that it sort of has a stalk at the bottom and it's sort of bigger on top. These are filiform. These don't have taste buds on them. They're just purely structural, and you can see that they're kind of short and pointy. And then foliate are going to be more of a boxy shape, and these are towards the back of the tongue. All right, so that ends our first lecture part. So now we're going to kind of jump into the lab portion of it, and there's 2 parts of this lab that I want to do. The first one is I want to have people sort of pair up if or groups of 2 or 3, whatever is convenient for you guys. So if you can do that, just kind of get in pairs. And we'll do just a quick kind of dental examination on each other, and then we'll go into the second part where I've been told that everyone has cow jaws. We actually had cow jaws, but they rotted and smelled really bad, so we have a deer jaw instead now. But we'll get to that in the second part. So if the instructors want to kind of pass out, I think there's dental dummies, like the little heads. They can pass those out as well, and the cow jaws while we go ahead and examine each other. So if you want to partner up, I'll give you just a little bit to do that. All right, so I'm hoping you guys have partners now. We'll go on to the next part. So when you're partnered up, just kind of have one person be the patient, one person be the fake dentist for right now. And I just kind of want you to have that patient open up their mouth and just try to look at the differences between the molars. Try to see, okay, how many cusps are on the molars? How many cusps are on the bicuspids? How many are on the canines? And just kind of look at that at first and just kind of note the differences, and then swap out and have the other person be the patient. And so just do that for just a few moments, and then we'll move on to the next thing. I'll just kind of walk you through step by step. All right, and once you've kind of examined the mouth a little bit, we'll do the same thing, but now we want to try to number it. So this is kind of tricky. So again, I described it as a sort of clockwise circle. I want you to look back. Maybe the person you're examining doesn't have a third molar, so remember, start with the second molar, but you want to start on the top right of the patient, and you want to count all along the top row and then all along the bottom row. So go ahead and take a few minutes and try to count how many teeth they have, and try to note maybe they're missing a tooth, maybe they're missing tooth number 18 or something. So just kind of appreciate how hard it is for dentists to count teeth. All right, and once you've done that, we're going to examine the tongue now. So if you've ever gone to the doctor, you know they've tried to look at your tonsils when they have you stick your tongue out and say, ah. So these are the structures I think we can probably see. You might be able to see the tonsils on some people if they still have them. That's going to be towards the back of the mouth on either side. But try to see if you can see some of these big circumvallate papilla. There's only like 11 or 14 towards the back of the tongue. And just appreciate that the tongue has a very rough surface. So just look at your partner's tongue and just kind of notice that and see if you can kind of differentiate the different papillae. Have them lift up their tongue, and you can see under their tongue there's a connection. It's called your frenulum. So you have your lingual frenulum under the tongue with two veins running, lingual veins running right beside it. So just take a few moments and just examine the tongue. And instructors, if you haven't already, go ahead and pass out the cow jaws and the extracting tools for that. All right, so now we will go to, we have a deer jaw here, but go ahead and get your cow jaws out if you have them. And I'll be using just a good old Craftsman wrench here. Well, I guess not Craftsman because it's made in China. But what we're gonna do is, this can be pretty tricky. I was trying to pull them out earlier on the rotted cow jaws, and it was not coming very well. So you might need to really pull hard to get some leverage. Or wiggle it. Or wiggle it. So you should be able to get, if you look at the cow jaw towards the front of the jaw, there should be a few incisors. And those are going to be much easier to get. You can at least break those off and pull those out. Now, when you go towards the back, you'll notice that the roots get bigger, the teeth get bigger. These are your molars, and they can be pretty hard. They can be pretty hard to pull out of there. So do your best if you can, but I think they're pretty tricky. And my phone doesn't go off. And just go ahead and start pulling teeth. So I pulled this one earlier, and it's already loose, so kind of came out easy. But you can see
that was cheap.
So I kind of cheated because I already did it earlier. But you can just appreciate the roots and the crown, and just kind of examine the occlusal surface and just think about, okay, what's a cow usually doing? Well, they're chewing grass and things like that, so they're grinding their food. And if you don't have enough cow jobs to go around, some people can go ahead and look at the models as well. But try to see if you can pull one molar and one incisor, and then just compare the roots. So you can see that the root of the incisor is much longer, and there's only one single root, but the root of the molar is much wider, and there's sort of two roots coming out of there. So just sort of play around with that, and we'll give you 10 minutes to pull some cow teeth. If you have any questions, just write in the text box and we'll try to explain, but really the best method is just grab the wrench and pull as hard as you can, and then just examine the surfaces of the tooth. So we'll give you 10 minutes to do that, and then we'll take a 10-minute break, and then we'll start back at 5:50 for the second portion. All right, guys, if you haven't already, you can go ahead and take your 10-minute break and we'll meet back. Again, we'll meet back at 5:50. All right, guys, we'll be starting here in a couple minutes. Just as you're ready, please send us a little chat in the chat box, and that way we'll start when everyone's ready.
All right, guys, we're ready to start again. And now that we've kind of looked in the oral cavity, we're going to look at your salivary glands in that area, and we're going to look at some of the neck muscles and talk through those. So we're going to go back over parts of the skull, some of the parts that Kyle's already touched on, and a couple extras just to get our bearings of where things are. The first one that I want to look at is a temporal bone, and as you can tell, it's a little bit basically all around your ear. This is where your ear would be. And then, so it's up and around it, down below it, and it goes out in front. This area that I'm highlighting with the mouse right here is part of the zygomatic arch. It's not the whole thing, but it's part of it. And the temporal bone forms part of it, and the zygomatic bone, which is this bone right here, forms the other part. We'll see more of the zygomatic bone in just a minute. Maxilla and mandible are the bones Kyle talked about. So obviously your upper teeth sit in the maxilla and the mandibles sit in your lower teeth. We are going to talk about the joint that is formed by partly by the mandible in a little bit. So I want to go into a little more depth of what the mandible looks like. So up close, you can see this is your condylar process in the back, and up front is the coronoid process. And then here is the angle of your jaw, which is an also important area. And of course, the alveolar process is where the teeth sit in. So just as a whole, from the lateral view, you can see, which means from the side, that's what lateral means. You can see different bones, the ones we talked about, maxilla, mandible, so the condylar process here, coronoids up here. And then this is a zygomatic bone here in green, and it forms part of the zygomatic arch, along with this brown bone here, which is a temporal bone that forms the other portion of the zygomatic arch. So now we're going to move into the salivary glands. Salivary glands obviously create saliva, and they contain two different types of cells. They have serous cells. Those cells make proteins. These proteins are actually enzymes. Enzymes are proteins that speed up the process of whatever they're working on, in this case, digesting food. And then mucus cells are another type of cells within salivary glands, and their function is basically to make the lubrication property of saliva. Salivary glands can be completely serous. They can be completely made up of mucus cells, or they can be mixed, in which case they have both serous and mucus cells. So you have major and minor salivary glands. As you might imagine, major is going to be larger. You have 3 pairs. You have the parotid glands, Those are your largest. Submandibular glands and sublingual glands. The minor salivary glands are much smaller. They're all over the mouth, and their ducts, which secrete the product that they make, lead to all over the oral cavity. And most of the minor salivary glands are mucus glands. Just as an overall picture of where your major salivary glands are, the parotid gland is going to be here in front of the ear, and its duct goes across a muscle and pierces another, which we'll get to in a minute. You have the sublingual gland near your floor of your mouth, underneath the tongue, and the submandibular gland, which you can tell is kind of near the angle of the jaw. And here, the jawbone is obviously, the mandible has been cut away, so you can see inside the mouth. So the first one we're going to look at, major salivary gland-wise, is the parotid gland. Location, in this picture you can tell it's underneath, inferior meaning lower than the zygomatic arch. This is the zygomatic arch here, and it is anterior or in front of the ear. And its duct, which secretes the product, so the enzymes in this case, goes over the cheek and goes into the mouth. This gland is entirely serous, so it only makes proteins. It doesn't make the lubrication properties of saliva. And these proteins are enzymes that, in this case, is called alpha amylase, that initiates the breakdown of carbs, or so sugar, and particular proteins that you eat. The parotid gland duct is also known as Stenson's duct. So location of the duct, it starts within the gland, which you can see in this picture. The parotid gland is green. The duct starts within the gland, and it goes over the masseter muscle, which we'll look at in a little bit, which is right here, and then it pierces another muscle called the buccinator. But it opens in the second superior molar tooth next to it. Superior meaning on top, so the top second molar tooth. And here is a picture of the opening of the parotid duct, and as you can tell, that's on the upper part of the mouth by the second molar, and you can see the opening right there with the arrow. The next thing we're going to talk about is parotitis, and this is something that can go wrong with the parotid gland. Just an FYI, itis at the end, so itis at the end of any word typically means swelling. So in this case, it's an inflammation of the parotid gland. There's several different causes of parotitis. One of the most common causes is a bacterial infection. The number one viral cause is something called mumps, which you've probably heard of. And one of the last main causes is blockage of the parotid duct. And that can be from a stone that forms in the gland that tries to pass through the duct. And we'll get to more about stones later. So signs and symptoms of parotitis. It depends basically on the reason that your gland is inflamed. So in bacterial causes or mumps, you get painful swelling of the gland. You might have a fever from the infection. And if it's caused the gland to get big enough, you'll have pain whenever you chew. One reason you could get unpainful swelling of the parotid gland is a patient that comes in with HIV. And treatment for parotitis is you have to treat the underlying cause. So if they have mumps, you have to wait it out. If they have a bacterial infection, maybe some antibiotics will help. And in some cases, they will, in different pathologies, pathology means disease, or essentially means disease of, and study of disease. So this is different diseases of the parotid gland. They may end up removing the gland. And when they remove it, they have to be careful of all these nerves right here. And all these nerves come back from here from the facial nerve. And the facial nerve has a lot of functions within the head and neck. And if you were here for our very first lecture of the year, Derek and Tahani talked about it. But in this case, it will be all sensory flow to the face. So you could, if they nick the facial nerve while taking out the parotid gland, they could lose sensation to the face. So the next major salivary gland we're going to look at is the submandibular gland. So this is as if you have taken the jawbone out along with some of the muscles that make up the floor of the mouth, and you can see part of the submandibular gland is inside the jaw. Part of it you would be able to see from the other view of the jaw as well. So it's at the back of the mouth and on both sides of the jaw. Something interesting about the submandibular gland is it actually produces 2/3 of all the saliva that you make. This gland is mainly, it's mixed, so it has both mucus and serous cells, but it's mainly serous. The submandibular duct, so here, you can see the gland, and here's the duct. It's green and runs this way. And it opens at the base on either side of the tongue, so underneath the tongue on either side of that. And another name for the submandibular duct is the Wharton duct. The last major salivary gland we're going to talk about is the sublingual gland. And that is basically in the floor of the mouth bilaterally meaning on both sides. And this is also a mixed gland, so it contains serous and mucus cells, but it is mainly mucus. I'm sorry that there's a mistake on your slides. It's mainly mucus. Sublingual gland is mainly mucus. Thought I corrected that, but I guess it didn't get changed. So just as a review again as to where all the major salivary glands, and you can look at it at once. So parotid gland is in front of the ear and underneath the zygomatic arch. The submandibular gland, here you can see the jaw's been cut away, but you would be able to see it on either side of the jaw. So it's in front of the jaw and behind it. And then the sublingual gland is underneath the tongue and the floor of the mouth. So a couple of different things that can go wrong with salivary glands. You can have stones. The stones are typically calcified structures, and they form in the gland itself, and as they try to move out, they can get stuck in a duct if they're big enough. The most common area to find them is the submandibular duct. And in fact, this picture shows one that's stuck in the submandibular duct. You can see this person, their tongue is up, moved it out of the way, you can see their frenulum of their tongue, and the duct opens right in the base of the tongue. So that is the submandibular, a stone stuck in the submandibular duct. So things that cause or could contribute to having salivary gland stones would not salivating enough. You produce less saliva, and that could be caused by dehydration, poor eating habits, or certain medications that patients take. If small enough, the stones would cause no issues, but if they are large enough, they eventually can cause pain and swelling of the gland that they are draining. So how do you diagnose somebody with a salivary gland stone? Typically, they see it on physical exam. Sometimes it takes imaging like ultrasound. And the treatment, so if it's a small stone, the reason that they have the stone is because they're not salivating enough. So what they're going to try to do is push the stone out by making the patient salivate more. And they do this by having them suck on a lemon or other sour candies. Or a dentist may actually try to massage it out. But bigger stones, they would have to make a small incision in the mouth and remove it. This stone over here, I would imagine would have to be removed by an incision because it is 2 centimeters long. The salivary gland stones is another picture. Here is a stone. You can see it's rather large, and it came from the submandibular gland. It actually caused the submandibular gland to swell to twice of its normal size. You can also have salivary gland tumors. These are very uncommon. They only make up 2 to 4% of the tumors that are found in the head and neck. The most common gland to find a tumor in is the parotid gland. And most of those are benign, meaning they aren't cancerous. Of the 30% left of salivary gland tumors, submandibular gland only makes up 8%, and the rest are in minor salivary glands. However, both of these categories, at least half or more than half, are malignant, meaning that they are cancerous. So signs and symptoms that they have a salivary gland tumor. If it's benign, it might just be a slow, painless growing mass, and that you can freely move, meaning if you find the mass, you can stick your fingers on it through the skin, obviously, and move it around. What would tell you as to what gland is affected is a location. So in the parotid gland, you might find it in the cheek region or at the angle of the jaw. Submandibular or tumor you might find at the angle of the jaw or in the neck. And then sublingual would be in the floor of the mouth. How you would know that it might be malignant is it would grow a lot faster than a benign tumor, and it was fixed, meaning it's not freely movable, and lymph nodes in the neck region might be swollen as well. If the parotid gland is affected, you might see facial nerve weakness. So here's a couple of different pictures of people with tumors of their salivary glands. Obviously, this one would be parotid. It's in front of the ear and down all the way down to the angle of the jaw. It's pretty nasty and big. Submandibular gland tumor, you can see it's just at the angle of the jaw and a part of the neck, not quite as big as that parotid gland tumor. If you see you have a sublingual gland tumor here, it's in the floor of the mouth. That thing is pretty monstrous, and it looks like they might have some other dental issues going on as well. So, new topic, we're going to talk about the joint formed partly by your mandible. It's called the temporomandibular joint. So it's a joint between your temporal bone and the mandible. It's also known as TMJ. So if I say TMJ, that's what I mean. The joint actually has a disc. So let me back up a minute. This is the area that we are zooming in onto of the mandible. So it's between the condyle of the mandible and the temporal bone is where you're going to find the disc for the joint. That disc divides it into a superior and inferior half. In case you forgot what superior and inferior means, superior meaning upper, inferior meaning lower. So if you look at this picture, you can see this is a superior or upper half between the disc and the temporal bone, inferior half being the lower portion between the condyle, the mandible, and the disc. As I just said, the inferior half is between the disc and the mandible, and the halves supply different types of movement for the jaw. The inferior half is for rotational movement, and that's just a fancy word for the beginning of opening of the jaw. The superior half is, again, between the disc and the temporal bone, and that allows for translational movement, which is a word to describe after you've opened your jaw all the way, the small amounts of movement you can do after it is all the way open is what the superior half of the joint contributes. So we're looking at some of the movements of the jaw. When we talk about these jaw movements, keep in mind the mandible is the only thing that is moving, not the maxilla. So these little movements I have shown at the bottom show the maxilla and the mandible moving. Try to ignore the maxilla and just think about the mandible. Couple of movements you already know is opening and closing of the jaw and chewing or mastication. Mastication means chewing. These two movements down here, protrusion, so sticking your mandible out. Retrusion is pulling the mandible back in. So one other movement you may have not thought about is lateral movements of the jaw, and it can go left or right. So this kind of shows the mandible going in one direction. So we're going to talk about muscles of mastication, so all the muscles that help you chew and also move the jaw. If we talk about the masseter, this muscle right here connects to the angle of the jaw, and it goes to the zygomatic arch. The main movement that it contributes is elevating the mandible, meaning it helps close the jaw. The temporalis goes from the temporal bone down to the condyle, or the cornoid process in the mandible, and it helps elevate the mandible as well. So it also helps close the jaw. This muscle also helps with retrusion of the jaw. So once you've stuck your jaw out, it helps you pull it back in place. These last two muscles of mastication are called the pterygoid muscles. You have a medial and a lateral. Medial means more midline, lateral is more out to the side. The medial pterygoid, they're both pictured in this picture. So the lateral pterygoid is in this pinkish color, the medial pterygoid is red. The movements of the medial pterygoid is that it can help elevate the mandible or close the jaw. And it can also help protrude the jaw, meaning push the mandible out. And it helps with lateral movements of the jaw as well when it contracts unilaterally. So if you just have one medial pterygoid contract, it can move the jaw laterally. Lateral pterygoid is going to be this muscle that's in the purple here. Again, it shows the medial. I like to show them together. Movements is, this is the only muscle of mastication that is involved in depressing the mandible or opening the jaw. So just remember that. It's the only one involved in opening the jaw. The lateral pterygoid, if contracting unilaterally, again, can cause the mandible to move laterally. And it also helps with protrusion or sticking out your mandible, your jaw. All right, so the reason we talk about this joint is because a lot of dentists have patients that come in with TMJ disorders, so they have a problem with this joint. As you can tell, this lady in the picture looks to be in pretty bad pain, and she is holding her hand right where that TMJ joint would be. So signs and symptoms would be pain and tenderness in the face or jaw, or they might have problems opening their mouth wide, or once they open their mouth wide, the jaw can get stuck when trying to close it. They might also hear a click or a pop when they open their jaw. Causes, so it could be issues with the jaw itself or the muscles that help move the jaw. And a lot of that can be from grinding or clenching teeth a lot. Say they had some sort of trauma towards their face, the disc itself could have moved, causing issues with the joint. Or just like any other joint in your body, you can get arthritis. Treatments, if they can have anti-inflammatories to try to help with the swelling, splint or a night guard, which that's what this picture is of. So they would wear that on their top and bottom teeth to help them from grinding or clenching their teeth. You can also have dental work to correct your bite if that is causing the TMJ disorders. All right, so we're going to look at some neck muscles now. So we're kind of changing topics. We're moving away from the mouth and going down to the neck. The first one we're going to talk about is the sternocleidomastoid. It's one of your larger neck muscles. The reason it's named sternocleidomastoid is it's talking about all the different bones that it's touching. So you can see in this picture, it goes from the mastoid process, which I know we didn't talk about. It's just at the back end of the temporal bone. So right where my mouse is back here, and it has two heads. It can touch the sternum here, or it touches the clavicle as well. The function of the sternocleidomastoid, whenever only one of them contracts, it causes your head to rotate to the opposite side and flex the neck to the same side. So to make that make more sense, if your right sternocleidomastoid contracts by itself, it will cause you to look to the left, and your right ear will be touching your right shoulder. If they contract at the same time or bilateral contraction, it can flex the neck and extend the head. If they have, so one thing that can happen when you have an issue with your sternocleidomastoid is a condition called torticollis. And that is just an abnormal asymmetrical head or neck position. We are going to talk about the congenital form, and meaning that kids are born with this. And the causes could be when they're still in the uterus, it could be in a weird position, or birth trauma causing damage to the sternocleidomastoid. So the positions of the baby's head will tell you which muscle is affected. So typically we'll lie flex to the affected side and rotate it away from the affected side. So in this picture, you can tell the baby is flexed to her right and rotated left. That means that her right sternocleidomastoid is probably affected. And a lot of times they will have a physical therapist come in and show them different stretches they can do at home, and the parents should work on them with that, and the problem will go away after they work on these stretches. We're going to talk about a specific group of neck muscles that I figure would be easier to see in the mink, so give you guys something fun to look at. There's this hyoid bone, and that is going to be in your neck. It's kind of like a floating bone. You can probably feel it. And the group of muscles above that bone, the hyoid bone, are called suprahyoid muscles, supra meaning above. And the group of neck muscles below the hyoid bone are called the infrahyoid muscles, meaning below, infra. And we are going to take a look at the infrahyoid muscles. They're much longer and not quite as small as the suprahyoid muscles. All right, so structures that are good to know when you deal with this group of muscles is going to be, as I've already talked about, the hyoid bone itself, the sternum, which I talked a little bit about with the sternocleidomastoid. This is what the sternum looks like, and it has three parts: the manubrium, which is the top part, the body, and then the xiphoid process. Really, all I want you to worry about today is the sternum in general, and knowing this is called the manubrium. And then the last structure it's good to know about in this group of muscles is the thyroid gland, which is right here. And the thyroid gland is a neat little gland that affects a lot of different processes in your body. The reason it's good to know these structures when dealing with this group of muscles is that all of their names are based on these structures. So let's take a look. I guess one more thing about the whole group itself is a function of all of the infrahyoid muscles is to depress or lower the hyoid bone whenever you swallow and whenever you speak. And the group is made up of 4 paired muscles. So the first one is the sternohyoid muscle. And that's going to go from the sternum. We can't see really where it starts here because the sternocleidomastoid is still covering it up a little bit. It goes from the sternum all the way to the hyoid bone. It's the one in pink here. The sternothyroid muscle is going to go again from the manubrium of the sternum to the thyroid cartilage. The thyrohyoid muscle connects the thyroid cartilage to the hyoid bone. And the last one we're going to talk about is the omohyoid muscle. And it has 2 bellies, an inferior belly meaning lower, which you can see I'm on right now, and a superior belly meaning upper, the one I have my mouse on now. So the inferior belly, and let me back up a second, those bellies are connected by a tendon, which is this white part right here. So the inferior belly goes from the scapula, or what you may know as a shoulder blade, to the tendon, and the tendon lies behind the sternocleidomastoid, which this is the sternocleidomastoid on the left side, so you can tell if it was on the right, so you would cover up that tendon that connects the inferior and superior belly. And the superior belly goes from the tendon to the hyoid bone. And this one is the most lateral of the infrahyoid muscles. All right, we're going to move on to the mink dissection. We're going to go ahead and give you guys a couple minutes to go ahead and get set up, get your minks, get gloves on, whatever you need. You go ahead and type to us and tell us whenever you are ready. Can we get a thumbs up when you guys are ready?
Oh, they're ready. Okay, good.
All right, we're gonna go ahead and start.
All right, guys, first thing that we want to do is just examine, we were talking about teeth first, and we had the cow jaws and things like that, but we just want to talk a little bit about the mink teeth. So just look at the mink teeth, try to pry open the jaw a little bit if you can. First thing you should notice, the very front tooth, very prominent canine, very sharp. And as you go back and you look towards their molars, you'll notice that those are sharp as well. And these guys are carnivorous. They eat a lot of fish. They eat shellfish, frogs, snakes, lizards, rodents, rabbits, birds, and eggs. So it kind of makes sense that they would just have very sharp teeth. So if you can, just kind of look in there, examine the teeth, and just think about the differences between them and us. And after you're done looking at the teeth, Maddie will take you through the muscle dissection of the neck.
All right, guys, so the first thing we're gonna do, let me proceed this by saying if I'm moving too fast, go ahead and type in the text box and let us know. I'm gonna try to go a little slower so we can know what we're looking at. But the first thing we're gonna do is look at two muscles of mastication we talked about. So we're gonna look at the temporalis. So if you had your mink with the stomach facing up, I want you to turn it to the side. You can see the temporalis might be underneath some fascia, which is this white stuff on top. And I'm going to peel some of that back just a little bit, enough just to see the muscle fibers. And it's going to cover from this part of the head down. So if you want to do the same as I am, go ahead and start on that. Just cleaning the muscle off. I don't have too much to clean off before I will start tearing the muscle, so just be careful. Some minks will have more fascia there than others. In fact, my fascia is not really thick enough to pull off without tearing some of the muscle. So if you can get an idea of which way the muscle fibers are running without cutting the fascia off, you can go ahead and do that. If you can't, if you have too much fascia there, it's too thick, I would suggest just looking at it a little bit like I am. There's no way I can get this off without tearing the muscle. So I'll just try to show you up close what it's more like. It's up here, and the fibers are running this way. Oh yeah. So just like our temporalis muscle is near the ear, because it's near the temporal bone, you can see that their ear would be right here, this dark little hole right here. The temporalis is right above that. It goes down this direction. So if you're having trouble visualizing where it's at, look for the ear and go right above that. All right, the next muscle mastication we're going to look at is a masseter. That is this muscle right here. And it is also covered in fascia, but not enough where I'm going to be able to take it off without tearing the muscle. I don't think. I'll work with it for a little bit, give you a close-up view of it. This muscle right in this area. So right here. So it's more in your cheek region. I can grip it and show you right there. I forgot that some of you are probably new tonight that weren't here the last time Kyle and I did a lecture talking about fascia. Fascia is this white connective tissue that lays over the top of some of these muscles, and it connects everything in your whole body, which is why everything kind of works together. And it's how things are kind of held in place. So that's what I mean by fascia. I'm just going to try to give you guys time to look around before we move on to the next area. If you guys notice, your muscles have fibers. The muscle fibers run in a certain direction. So if you are able to get that fascia off without ripping the muscle, you can see which direction those fibers run in. And your muscle actually contracts in the same direction parallel to those fibers. So you can kind of imagine the type of movements that they can do based on that. All right, if you guys are ready to move on, one last thing that we talked about was, this is not the last thing we're looking at, but one last thing with the mouth before we move on to the neck muscles is the submandibular gland. The glands don't, and humans as well, they don't preserve the greatest, so you can't really take them off, but you can pick them off piece by piece if you want to. I just want to show you where it's at. I'm just going to grab it with my forceps here and just show you the general area as to where it's at. So it's going to be on them a little bit behind the ear and more underneath on the bottom side of them. And it kind of looks like fat. So if you start tearing it off, there probably is some fat on top of it, but after that, it easily plugs off. Maybe not so easy in minks as it does in humans. But so yours might have a little bit of tough connective tissue on top as mine does, and then underneath it'll be easier to peel off if you want to. If you don't want to, you can leave it there. It doesn't matter to us. I just kind of wanted to show you the general area that it's in. So again, near their ear on them, but more on the underside of them right here. So like I said, generally they don't look like anything special there. The camera. All right, so the next thing we're going to look at is some of the neck muscles. One thing I want to point out, we'll look at it later in case you can't already see yours, but since they have already been dissected, you may already be able to see their trachea, which of course allows air to travel from their nose down into their lungs. So this right here, this tube is that I'm pulling up on is their trachea. Yours might be covered up by neck muscles if it hasn't been dissected very much. You can feel that, and it feels kind of hard. It's made up of a certain type of cartilage, different than the cartilage that would be in your ear, which would be elastic. This is more fiber cartilage. It's like fiber cartilage is just a little tougher. You can press on it because it's a hollow tube. But so if you can see the trachea, you can use that as a clue for some of your neck muscles we're going to dissect. If not, you will see it later after you take some of the neck muscles off. So the first thing we're going to look at is the sternocleidomastoid. And that goes down from behind the ear down to the sternum and collarbone or the clavicle. So the first thing I'm going to do, you can see it here and here on either side of the trachea. The first thing I'm going to actually do, though, is take some of this fat off so we get a better view of what it looks like. There's a lot more fat on this side that I'm working on than the other. So if you just want to work on one side, I would suggest the side that has less fat to deal with. Now, as you're cutting, you might actually see the submandibular gland again. It's right here. And it just looks like a bunch of tiny circles or globs of fat, like we were talking about earlier. And you can cut that out of the way if you would like, if you haven't already done so. And if you can, I would clear off the entire sternocleidomastoid area, so back to the ear area, all the way down to the chest, so that we can cut either the superior end by the ear or the inferior end by their sternum, so we can pull it back and make the other neck muscles easier to see. So I'm gonna give you guys time to keep cleaning. Can some of the instructors give Kyle a thumbs up as to whether we're ready to move on, or most of us are ready to move on? I don't want to do anything too early, so.
Very good.
All right. So I've uncovered both sternocleidomastoids. One is much better than the other, so I'm going to use my better side to show you guys stuff. So here it is on this side. However, on this side, you can see it going all the way up towards their ear. So I'm going to use this side as hopefully a better view. And what I'm going to do, I'll talk to you about it before I do it. I'm going to cut it from the superior end and pull it down inferiorly. So I'm going to cut it from the top end near the ear and pull it down towards the sternum so we can see some of the muscles that lie underneath it. And be careful before you do that if you've already done it, all right? But you typically will be able to see some connective tissue connecting it to the muscle that's underneath it, and that way you don't cut more than just the sternocleidomastoid. So if you see fascia, I would just cut right in that plane all the way down. It's a fairly big muscle, and like I said, it's one of your bigger neck muscles that actually has stuff go wrong with it, such as the torticollis that we talked about earlier. That's why I kind of wanted to look at this one. All right, so typically what you're gonna find, and in mine, I don't see it, so I'll lead you through what should be there. So with the peeled back the sternocleidomastoid, and we see a muscle laying right next to the trachea. It should be your sternohyoid, so it's gonna go all the way from your sternum up to your hyoid bone. And lateral to that, or on the side of that, meaning out towards the side, you should be able to see another muscle, and that would be your sternothyroid. So I don't see mine there. I'm going to do a little bit of digging in this fat. I don't really expect to find it. Not really sure as to why, because I don't see that it came up with my sternocleidomastoid. You might check the underside of your sternocleidomastoid to see if you can see if you cut more than one muscle. Possibility. And so once again, the sternohyoid is supposed to be more midline, and sternothyroid would be on the side of that. And like I said, I did not expect to find mine, and I don't believe, well, give me 1 second. No, I did not find my sternothyroid, but yours would be just on the other side, so right over here of your sternohyoid. So your sternohyoid is closest to your trachea. Right. Just for fun, I'm going to show you a couple other structures, and then we'll be done for the evening before you take your quiz. So if you found your esophagus, you lift that up. I'm sorry, if you lift up your trachea, I'm sorry, if you found it, lift that up, and there should be a band of muscle underneath that, and it might be stuck to your trachea. You can separate the two pretty easily. So here is my trachea, and right underneath that would be your esophagus, which we talked about in the last class that we had. The esophagus takes food from the mouth all the way down to the stomach. So that's one cool thing to look at. And then the last thing I saw that's kind of cool, you see this vein right next to the trachea, and that is going to be the internal jugular vein, which is going to drain blood from a lot of different areas of the body and take it down towards another vein that'll dump into the heart. If you look, one last thing for real this time. Let me peel this back a little bit. You'll be able to see one last vein. If you go to the side of the sternocleidomastoid and try to do this without cutting the vein, you can find your external jugular vein. So it's right here. Thanks for joining us tonight, and I hope you guys had fun this year. We've had a lot of fun teaching you guys.